So I hope it's working now. Okay. Yeah, okay, so we will start working here. So we'll start again from the beginning. So my name is Mohammed El Dakak. I am a doctor in the Southampton University Hospital. Today our topic with the second batch of the lectures of Moonlight Academy will be about uveitis. We will talk mainly about the art of history taking and diagnostic clues. So we are so concerned about the history because it's very important for you to take a good and detailed history from these patients to be able to reach the correct diagnosis. So the keys for the diagnosis of uveitis are mainly the thorough history, the good physical examination, including the ocular examination, and also the review of systems either by the clinical examination and also the lab workup you will do for diagnosis of the etiology of uveitis. The history is very important because after the history you can reach a correct diagnosis in about 56% of patients, and this percentage can be raised up to 73 if you completed your examination for those patients. So the history can give you a very perfect and correct diagnosis in more than half of your patients with uveitis, and the percentage can be raised up to 73 or 3/4 of those patients after finishing your examination. So the routine laboratory evaluation or workup for those patients just help you for establishing a diagnosis in only 5% of patients. So I'm sure with taking the detailed history, you'll be able to reach your correct diagnosis even before starting your examination. Always remember that you need to follow the straight and good way for reaching your diagnosis and to break through the obstacle in your diagnosis to reach the correct diagnosis, and don't follow the people that are taking long ways for getting the diagnosis, like you can see here, and use the simple and correct manner in breaking the obstacle between you and the correct diagnosis by doing a good history. So this is the first step in the diagnosis is history. So the questionnaire about the history is you need to know what to ask and how to ask, when to ask, and the clues in this diagnosis. So again, what to ask, how to ask, when to ask, and the clues in your diagnosis. So this is very important for every item in the uveitis. So the history, mainly the main history or the history, as you are taking a history for any patient. So it's important to take the personal data first regarding the name, the date of birth, so the address, weight. The date of birth is important because the age of the patient is very important for excluding specific types of uveitis. As some uveitis patients, the etiology can be guided by the age, because in those patients with young age, for example, in those patients with juvenile rheumatoid arthritis, so mainly the age group is children in those patients with suspected ocular lymphoma, for example. So the main group is all elderly people over 70 years old, and so on. So it's important for the personal data of the patient is important for giving you some clues in the diagnosis of uveitis. The ocular history, the complaints, is very important because the complaint can give you a clue for the type of uveitis you are dealing with. So if you have a patient complaining of photophobia, blurry vision, redness, pain, so probably this is an inflammation in the anterior uvea. So the anterior uveitis is the most probable diagnosis. If you have a patient with floaters in the vision, with blurry vision, so you will suspect an intermediate uveitis or posterior uveitis. If there is a severe drop of vision, so the posterior uveitis involvement of the retina can be the cause of this severe drop of vision. The history of recurrent attacks of uveitis is very important. The history of trauma, because the trauma can be one of the contributing factors of uveitis. If you have a traumatic uveitis, the history of surgery, if the patient develop an infectious uveitis following surgery, or if there is any surgeries that can be related to complications of old uveitis in the eye. So it's very important. And also any ocular diseases and drugs that can be contributing to the uveitis, very important to be excluded as well. So the drugs or the eye drops that the patient is using, so it's very important. So if those patients is taking drugs that can be contributing to uveitis, like prostaglandin analogs, or in treatment of glaucoma, and those drugs that are proved with case reports that can cause uveitis in the eye. So it's very important to be excluded as well. So the medical history is the chronic diseases, including the systemic disease like diabetes, hypertension, history of surgeries, history of serious injuries involving other parts of the body, history of hospitalizations, history of sexual transmitted disease. The review of system through direct questionnaire, we will we'll put a system for direct questionnaire uveitis to put a direct questionnaire of those uveitis patients, and also the family history of uveitis or any related medical conditions, including the HLA-B27 associated spondyloarthroposis, any medical conditions that can be inherited and can be a cause of uveitis. So this is very important also to be excluded in the family history. The drug history is very important. There are proven drugs that can cause uveitis. So it's very important to take the detailed drug history of those patients and to correlate if any of those drugs is involved in the etiology of uveitis or not. And lastly, the social history, the place of birth of those patients with the prevalent causes of uveitis according to the place of birth, the job and the exposure and the visual impact of uveitis on the patients according to his visual needs with his job or her job. We travel to specific areas that can has an epidemic or a pandemic of some infection and can be one of the causes of uveitis. The travel, as we mentioned, the ethnic group, it's very important, like in those patients with Behçet disease in the Mediterranean area and those patients with black races with sarcoidosis. So it's very important. The origin the patient came from is important for excluding specific types of uveitis. The smoking, which can be a risk factor of developing recurrences in uveitis, specific types of uveitis like HLA-B27 associated uveitis. The diet, if there is any nutritional deficiency, the growing of pets like cats, dogs, in the Toxocara prevalence in those patients exposed to dogs, for example, and toxoplasmosis with patients exposed to cats. The sexual behavior and sexual transmitted disease and the history of any of those can be one of the important clue in your diagnosis of uveitis, and also exposure to tick bites with possibility of those patients to have a Lyme disease or Borrelia burgdorferi infection in those patients. So again, it's very important to be sure that your uveitis uh, uh, is entitled with one of those risk factors according to the main history of the patients. So the history of uveitis itself. So the main part of the taking the general information about the patient, but the history of uveitis itself is very important as well. So starting from the complaint of the patients, the patient complaint can be a very important guide for you to diagnose the type of uveitis or the location of the inflammation in the eye. So if you have a patient with photophobia, redness, and pain, or sometimes maybe asymptomatic, so the most probable diagnosis here is the anterior uveitis. In those patients with floaters and plus or minus decrease in the visual acuity, so the intermediate uveitis can be one of the possibilities. Those patients with photopsia, floaters, severe decrease in vision, and with visual field defects, so the posterior uveitis will be the most probable diagnosis. So this is regarding the complaint. The ocular history is very important as well. So if you are taking a good history about the condition of uveitis, how it starts. So if the onset was acute and sudden, so this is an important thing. If this is a chronic or starting over a few days or a few weeks, so this is very important. So the duration and course also of the uveitis is very important. So if it's progressive, if it's regressive, if it's intermittent in symptoms, if the duration is days, weeks, months, so it's very important. The laterality, if the patient has a unilateral involvement or bilateral. So if it's unilateral and recurrent in one eye rather than the other eye, so the probability of infection is higher here. But if it's bilateral, so you should put in your mind that it may be something that can induce bilateral involvement and like a systemic disease the patient may have with as a contributing factor in uveitis. So if it's painful red, most anterior uveitis patients can report pain and redness in the eye, but in those patients with painless and white eye without any with quiet and totally white eye, like those patients with juvenile rheumatoid arthritis, so in those patients you will not report any pain or redness in the eye. So the presence of pain and redness and is very important if the eye is quiet with the attacks of uveitis of the eye is severely inflamed and painful with attacks of uveitis. Also, the demographics from the patient, from where the patient came, or the distribution and the demographic distribution of the specific types of uveitis, as we mentioned before, in those patients with basic disease with more prevalence in Mediterranean area, and those patients with sarcoidosis and those patients with ocular histoplasmosis, for example, in specific demographic distribution. So this is very important. The response to steroids, if the patient had steroids before, and what was the response to steroids, if there was an improvement, if the patient had a good response to steroids, or the patient either topical or systemic, or if the patient didn't have a good response to steroids. So this is a very important issue. And of course, the previous episodes of uveitis, the surgery in the eye, the trauma, as we mentioned before in the detailed general data about the patient. So this is the end of the first important topic in the history taking, which is the general data about the inflammation itself and also about the patient with uveitis. The second issue is the systemic review for uveitis, and we are here concerned about asking a very specific questionnaire to cover all the systems and to collect the positive data from any of the systems that can be correlated to uveitis the patient has. So we need to ask about the positive history or positive data from the head, neck, CNS symptoms. We need to ask about the symptoms involving the ear, nose, throat. We need to ask about the symptoms involving the pulmonary system and chest. You need to ask about symptoms involving the gastrointestinal tract. You need to ask about symptoms involving the genitourinary tract. You need to ask about symptoms involving the skin and dermatological complaint in those patients. You need to ask about symptoms involving the musculoskeletal system. And also you need to ask about constitutional symptoms and prodromal symptoms that precede uveitis, if there is any. So this is the main thing about the systemic review for uveitis. So we'll start first with taking the positive data and symptoms related to the head and central nervous system. So the main symptoms you need to ask the patient related to those systems is if the patient has frequent or severe headaches, if the patient has history of any fainting, if the patient has history of numbness or tingling in the body, so if the patient has any paralysis in any part of the body, if the patient has seizures or convulsions. So those are the main symptoms you need to ask the patient about, and the patient should exclude that he has or he didn't have any of those symptoms before. And based on the history of those symptoms, you can be able to exclude certain diseases. So, for example, if the patient has history of headaches, so there's a broad spectrum of diseases which can be a cause of uveitis and also can be presented by headache. Those involved the Vogt-Koenige harada, the sarcoidosis, the Behçet disease, the tuberculosis, the herpes zoster, large cell lymphoma, polyarthritis nodosa, cryptococcus meningitis, toxoplasmosis, and Lyme disease. So in those patients with headache, you need to exclude any positive data related to those diseases. So, for example, in patients with Vogt-Koenige harada, if you are suspecting with headache, the Vogt-Koenige harada, so you need to ask about other skin lesions with Vogt-Koenige harada, other auditory symptoms, other central nervous system symptoms. And in those patients with sarcoidosis, you need to ask about chest condition, about the other granulomatous lesions, any parts of the body. In those patients with Behçet, you need to ask about orogenital ulcers. In those patients with tuberculosis, chest symptoms, herpes zoster with characteristic inflammation of shingles, the large cell lymphoma in those patients with old age and masquerade syndromes with if you are unable to define a specific etiology, those patients with polyarthritis nodosa with history of vascular lesions and also vascular symptoms, cryptococcus meningitis and toxoplasmosis, Lyme disease with history of correlated symptoms as well. So the cranial neuropathy can be found in those patients with Lyme disease, in those patients with sarcoidosis, with granulomatous infiltration of those cranial nerves, in those patients with multiple sclerosis, with demyelinating patches in those nerves, in those patients with syphilis, and in those patients with herpes simplex virus. So the patients with psychosis can be The psychosis can be because of vertigo-nagi-harada, can be because of Behçet, can be because of systemic lupus erythematosus. Any of those diseases can be presented by psychosis. The most important is to define if the psychosis is related to the etiology of uveitis, is related to the drugs you are giving for treatment of uveitis. So, in the patients with I after starting the oral steroids, as the steroids themselves can induce psychosis in some patients. So those patients with vertigo-nagi-harada, with Behçet disease, with systemic lupus erythematosus, the psychosis can be part of the etiology of uveitis. If you have a history of cerebral vasculitis in some patients, so you need to exclude those etiologies like acute posterior multifocal placoid pigment epithelial, and this will be easy with the clinical findings of fundus examination. The Behçet disease, characteristic vasculitis in the retinal blood vessels, the herpes simplex virus with history of involvement of the vessels and herpes simplex complicated by vasculitis, and also the herpes zoster virus. Those patients with syphilis and those patients with Lyme disease, all of them can be presented by cerebral vasculitis. So those are the main items related to the head and central nervous system symptoms. So the other important thing is the ear, nose, and throats in involvement with any of the systems. Okay, so so you need to ask about some symptoms related to the ears. You need to ask the patient if he or she has any hard of hearing or deafness. You need to ask if there is any ringing or noises in the ears. You need to ask about the frequent or severe ear infections that happened to this patient before. You need to ask about painful or swollen earlobes with inflammation of the ear pinna or auricle. So this is very important in diagnosis of relapsing polychondritis. So also in the nose and the throat, you need to ask about sores in the nose or mouth, about the severe or recurrent nosebleeds, about frequent sneezing, about sinus trouble, about persistent hoarseness with possibility of laryngitis, about tooth or gum infections. So symptoms you will ask. So you will ask about any difficulty of hearing, any ringing or noises in ears, any frequent or severe eye infections, any swollen earlobes or inflammation, any nosebleeds, any sores in the mouth, any frequent sneezing, any sinus trouble, any persistent hoarseness, any tooth or gum infections. And based on these symptoms, so you can correlate them with some etiologies of uveitis. For example, if you have a patient with bilateral ear pinna inflammation and had history of recurrent inflammation in the auricle, so you need to exclude the relapsing polychondritis. If you have a patient with auditory and vestibular symptoms, there is a broad spectrum of diseases that can cause auditory and vestibular symptoms as a pathology of the vestibulocochlear nerve or one of the symptoms of the disease itself. So the vertigo-nagi-harada can be presented with auditory and vestibular symptoms, the sarcoidosis, the Wegener's granulomatosis, the Eales disease, and the syphilis. Also, the lymphadenopathy is one of the things that you should look for in those patients with uveitis if there is a preauricular lymphadenopathy. So if you have an enlarged lymph node, so this means that you need to exclude the lymphoma, you need to exclude the HIV infection and toxoplasmosis infection. So those are the main issues with exclusion in ear symptoms. Regarding the nose and the throat, if you have a patient with saddle nose deformity, so you need to exclude syphilis, Wegener's granulomatosis. You will ask those patients with syphilis about sexually transmitted disease infection, and Wegener's granulomatosis if there is any sinus infection before, or any inflammation in sinus, any chronic inflammation in sinus, or any history of inflammation in the orbit with idiopathic orbital inflammatory disease, which was treated before by steroids. Also, the relapsing polychondritis can be presented with saddle nose deformity, and also, as we mentioned before, with bilateral ear pain inflammation. The presence of oral ulcers is one of the very important signs of some diseases. It's not only the BESID, but you have many categories of the disease can be presented by oral ulcers. The BESID is one of them, but still the systemic lupus erythematosus can be presented by oral ulcers. Also, the herpes simplex with eruption of the vesicular eruption of the herpetic lesions can be presented by oral ulcers. The Reiter syndrome with history of conjunctivitis and epididymitis by oral ulcers. The ulcerative colitis and the inflammatory bowel disease can be presented by oral ulcers as a part of the disease, which is involving also the intestine and can cause gastrointestinal tract ulcers. Also, the sinusitis can be one of the symptoms of sarcoidosis with recurrent granulomatous inflammation, and also the Wegener's granulomatosis can be one of the sinus inflammation, can be presented by recurrent sinus inflammation, and this inflammation can be also involving the eye with idiopathic orbital inflammatory disease, or can involve other parts of the face with granulomatous inflammation. Also, the salivary lacrimal gland swelling can be part of the lymphoma or sarcoidosis inflammation, and those should be excluded as one of the etiologies of uveitis. So we mentioned the head and CNS and the ear, nose, and throat, and now we are moving to the respiratory symptoms and the pulmonary symptoms. So you need to ask about specific symptoms in the respiratory tract, including the severe or frequent colds, the constant coughing, the coughing up blood, the recent viral infection, the wheezing or asthma attacks, the difficulty in breathing. So if those patients have any severe or frequent colds, if there is a constant coughing, if there is coughing up blood, if there is recent flu or viral infection, if there is a wheezing or asthma attacks, if there is difficulty in breathing. So the pulmonary symptoms we mentioned will be highlighted if you have any of those, and will be a very important guide for you to reach the correct etiological diagnosis for uveitis. So in those patients with cough or shortness of breath, so you need to think about tuberculosis, sarcoidosis, pneumocystis carinii, malignancy, Wegener's granulomatosis. In those patients with findings in the chest X-ray, if you find nodules, if you find hilar lymphadenopathy, if you find a lung infiltrate, so you need to exclude the ocular histoplasmosis, you need to exclude sarcoidosis with hilar lymphadenopathy, you need to exclude malignancy as a part of the masquerade syndrome if there is a uveitis in the eye without an explained etiological diagnosis. Also the tuberculosis, also the pneumocystis carinii infection, and pneumonia. So those are the one of the important things you need to correlate with the chest X-ray of the patient and the history of uveitis. So So the gastrointestinal tract system, the symptoms you need to ask about is trouble swallowing, if the patient has a history of diarrhea, any history of bloody stools, any history of stomach ulcers, any history of jaundice or yellow skin. So this also need to be reported for those patients to as a positive data if the patient has any of those symptoms, and you can correlate it more with the specific entities of diagnosis, like if the patient mentioned that he or she had history of recurrent diarrhea, so you need to think about inflammatory bowel disease like Crohn's disease, ulcerative colitis, Weber disease. Each one of them can have its specific diagnostic criteria and some other systemic involvement like joints involvement and history of malabsorption and loss of weight, for example, in Weber's disease with steatorrhea and all these issues. So it's very important to exclude the history of inflammatory bowel disease in those patients with chronic diarrhea. If the patient has history of jaundice or hepatosplenomegaly, you will think about infections like brucellosis. So you will ask those patients if in diet he is taking milk without boiling or as a source, as a possible source of infection of brucellosis. If the patient has a history of cytomegalovirus infection, which is presented by hepatitis as well, and history of complicated hepatitis with jaundice and hepatosplenomegaly. If those patients with sarcoidosis and involvement of the liver with granulomatous inflammation of sarcoidosis, so the patients can have liver nodule or sarcoid nodules in the liver, so it needs to be also excluded. In those patients with history of jaundice with infectious hepatitis, like hepatitis A or B or C virus, so this is very important. And autoimmune hepatitis as well can be one of the causes that can be associated with uveitis in the eye. So, so this is related to the gastrointestinal tract symptoms and the liver. So in genitourinary symptoms, you need to ask about kidney problems, about bladder trouble, about blood in the urine, about any history of urinary discharge, about any history of genital sores or ulcers, about any history of prostatitis or epididymitis or testicular pain with epididymitis. So the patient should exclude these symptoms by answering them through direct questionnaire. If there is any kidney problem, if there is any bladder trouble, if there is any blood in the urine, if there is any urinary discharge, any genital sores or ulcers, any prostatitis, any testicular pain, and history of epididymitis. Also, in female patients, you need to clarify that if the patient is pregnant or not, or if she is planning to be pregnant in the future. So this is very important in your management. So you will be restricted if the patient is pregnant. So certain drugs can have some precautions during pregnancy. So you will not be able to put that in your plan of management in those patients. And also, if the patient is planning to be pregnant in the future, so this is very important to be reported because some immunosuppressive drugs or immunomodulator drugs can be a very risky factor for fertility and for planning the pregnancy for those patients. So it's very important to report all of these. So the genitourinary symptoms also is very important, as you mentioned. So if you have a history of genital ulcers, so you need to exclude the Behçet disease. Sorry, just to be sure that we okay. So in those patients with genitourinary symptoms, with genital ulcers, you need to exclude the Behçet disease, you need to exclude the Reiter syndrome with conjunctivitis, epididymitis, and if there is any, you need to exclude also the syphilis as one of the sexually transmitted diseases by laboratory workup, as we will laboratory and rapid plasma regain. In those patients with hematoma, so you need to exclude the Wegener's granulomatosis as it involves the kidney. You need to exclude the polyarthritis nodosa with involvement of the kidney. You need to exclude the systemic lupus erythematosus with nephritis associated with systemic lupus erythematosus. In those patients with succinate balanitis, so it's very important to exclude the opposing spondylitis or HLB20 associated spondylitis and Reiter syndrome, as one of these can be presented with succinate balanitis. Also, in those patients with urethral discharge, so it's very important to exclude the Reiter syndrome and the syphilis as one of the possible diagnostic entities. The nephritis, as we mentioned, so the involvement of the kidney in many diseases that can be a cause of uveitis is there, but mainly the polyarthritis nodosa, the Wegener's granulomatosis, the tubulointerstitial nephritis with uveitis, and it is a very important entity in the diagnosis to exclude the presence of nephritis in the patients with uveitis. In those patients with a history of testicular pain and the epididymitis, so you need to exclude the polyarthritis nodosa, you need to exclude Behçet disease and Reiter syndrome. Okay, so this is related to the genitourinary symptoms. In addition to the dermatologic symptoms, so the symptoms you will ask in the skin of the patient, you will ask those patients if there is any history of rashes, if there is any history of skin sores, if there is any history of sunburn easily with photosensitivity to sunlight, if there is any history of white patches of skin or hair or vitiligo, if there is any history of loss of hair with alopecia, if there is any history of tick or insect bites, should be reported. If there is any history of painfully cold fingers with possibility of Raynaud's phenomena and vascular element that can be contributing to diminished blood supply to the periphery, if there is any history of severe itching in those patients. So again, the rashes, the skin sores, the sunburn, the photosensitivity, the white patches of skin or hair, the loss of hair, the tick or insect bites, the painfully cold fingers, and severe itching. So the alopecia is one of the important signs of the Vochtic-Wanagi harada and syphilis, as you all know, and the vitiligo and poliosis also for the Vochtic-Wanagi harada disease mainly. Of nodules is one of the criteria of presence of sarcoidosis or systemic lupus erythematosus, leprosy, or inflammatory bowel disease, Crohn's and ulcerative colitis. Also, the presence of rash, the skin rash, can be one of the symptoms of diseases, including syphilis, Lyme disease, Reiter syndrome, leprosy, sarcoidosis, herpes zoster, systemic lupus erythematosus, and Kawasaki disease. So any of those diseases can be presented by rash. So the history of syphilis should be excluded. The history of Lyme infection or Borrelia burgdorferi infection should be excluded either by the clinical findings or by history of tick bites. The history of Reiter syndrome with presence of urethral discharge or conjunctivitis, and the history of leprosy if the patient has history of Treponema leprae infection, if the patient has history of sarcoidosis with granulomatous inflammation involving the lungs and involving the other tissues. If the patient has a history of shingles or herpes zoster, Behçet disease, if the patient has a history of orogenital ulcer Behçet disease, or patient has a history of psoriasis with skin lesions that is characteristic for psoriasis, with exfoliation, if the patient has systemic lupus erythematosus with characteristic malar flush and also the alopecia and the systemic symptoms involving other parts of the body, the joints, the heart, the chest. Kawasaki disease, which is mainly presented in childhood with involvement of the with vascular involving the arteries or veins, and can be presented in the eye with peripheral vasculitis as well. So those are the main important topics related to the rash. If there is history of keratoderma plenoragicum, which is a characteristic scarring vesicular eruption in the extensor aspects of the arms, as you can see here. So this is one of the criteria of Reiter syndrome or ankylosing spondylitis. So both of them should be excluded by asking about lower back pain with ankylosing spondylitis or history of urethral discharge and conjunctival infection in those patients with suspected Reiter syndrome. The erythema nodosum with characteristic is very important to exclude in the history if Behçet or has history of focal placoid pigment epitheliopathy. The three can be presented by erythema nodosum and the characteristic skin lesion in the diagnosis. So this is related to the dermatological symptoms. So the musculoskeletal symptoms, you need to ask those patients about the specific symptoms involving the musculoskeletal system, which is stiff, history of painful or swollen joints, if there is any stiffness in the lower back, if there is any back pain while sleeping or awakening, if there is any muscle aches. So this is very important to be in the history of those patients. So again, stiff joints, painful or swollen joints, stiff lower sleeping or awakening, and muscle aches. So if there is any history of arthritis, so most of the rheumatological disease and also the disease that can involve the vessels can be presented by the arthritis. So you have a very broad spectrum of disease that can have history of arthritis with them, including the Behçet disease, sarcoidosis, systemic lupus erythematosus, the juvenile idiopathic arthritis, the Lyme disease, the syphilis, the psoriatic arthritis, the Reiter syndrome, and the ulcerative colitis. In those patients with history of sacroiliitis, with stiffness in the lower back and lower back pain, or difficulty awakening in the morning because of the lower back pain, so you need to exclude the HLA-B27 associated with spondyloarthropacies, including the ankylosing spondylitis, Reiter syndrome, and inflammatory bowel disease. Of course, the age of the patient is very important. So if the patient is very young and has history of stiffness in the lower back and the lower back pain, which is not related to stress or effort, so the probability of having HLA-B27 associated spondylar arthropacies is higher. So you need to exclude that by lab workup and to have the HLA-B27 workup for those patients. Also the history, as we mentioned before, for diarrhea, for steatorrhea, for any history of liver involvement, jaundice, hepatosplenomegaly. So this is needs to be clarified in the history of the patients. So So again, the musculoskeletal systems, you need to ask mainly about the arthritis and arthralgias and tendon swellings and joint swellings and muscular pains, and also the stiffness in the lower back pain with which can be a clue for diagnosis of HLV27 associated spondyloarthropathies, and you need to have either X-ray or CT for sacroiliac joint to confirm your diagnosis in those patients. So this is the end of the main review of symptoms, as we mentioned before, but still the constitutional symptoms can be a very important guide for you with these entities. So you will ask those patients if there is any history of fever, if there is any persistent or recurrent fever, if there is any history of night sweats, if there is any history of fatigue or easily tiredness, if there is any poor appetite with loss of weight and 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 especially with disease involving the gastrointestinal tract, if there is unexplained, with the general condition of the patient, is the patient severely ill, like in those patients with autoimmune disease, or patients with chronic illnesses, or patients with cancer, or suspecting tumors. So this is very important to be excluded. The fever is one of the clues in the diagnosis of Reiter syndrome, Behçet disease, polyarthritis nodosa, inflammatory bowel disease, HIV, tuberculosis, coccidomycosis, Weevil disease. So all of these diseases can be prevented by fever. Also, the night sweats is very important for excluding the tuberculosis. Also, it's one of the important symptoms in those patients with malignancy, or those patients with sarcoidosis or with mycosis. So the night sweats should be highlighted in those patients if there is a preceding prodromal symptoms or flu-like symptoms preceding the history of uveitis. So this is important to be reported, because it can be to differentiate between multifocal segment epitheliopathy or multiple luminescent white dot syndrome. Both of them are part of the white dot syndrome. Also, flu-like symptoms with infection, like history of infection with tick bite, with possibility of Lyme disease. So it's very important to have that in your history. So this is related to the constitutional symptoms. The drug some diseases that some drugs that can be associated with uveitis. So the drug history, the drugs that have been reported to be associated with uveitis are many, but the rifabutin, the bisophosphonate, the sulfonamides, the quinolones, and anti-tumor necrosis factor. Despite the anti-tumor necrosis factor are used for treatment of uveitis, still the can be associated with uveitis in some patients. So there are reported cases of bisphosphonate, sulfonamides, quinolones, and anti-tumor necrosis factor. So this is related to the drug history. the family history, the patient should report if there is any of those family history diseases questionnaire to those patients. The patient should answer is anyone have history of diabetes, arthritis, rheumatism, syphilis, tuberculosis, citrate, Lyme disease, and gout. Again, so those should be excluded by the patient through taking a detailed history. So you need to exclude the presence of cancer, diabetes, syphilis, tuberculosis, sickle cell disease or trait, Lyme disease, and gout. Specifically, you need to ask about any family history that is related to the one of the systems that we mentioned before. So any have a problem with eyes, any family history of uveitis or any other eye problems, any family history of skin, any family history of kidney problems, any of lung problems, family history of stomach or bowel problems, any family history of system or brain problems. History of uveitis and you know the inheritance of the HLB27 associated uveitis. So it will be reported in the history of the eyes if there's any members have history, and if there is any history of skin lesions that can be correlated to one of the pathologies of uveitis. If there's any history of nervous system or demyelinating lesions with multiple that will be cleared in the history and can be correlated to the condition that the patient have. If there is any history of inflammatory bowel disease, lung condition, including sarcoidosis and tuberculosis, and the infection of tuberculosis, for example, can be transmitted in families because of the possibility of infection with family members. So it's very important to report any of those. So this is the end of the family history. The importance of the social history is will be highlighted in specific items. So the place of birth is very important because some patients can come from another ethnic origin or another place that has a prevalence of specific types of diseases that can be associated with uveitis. So it's very important to report the place of birth, the job. The importance of job is related to the visual impact of the condition of uveitis on those patients. So, for example, so if the patient is working as a doctor and the visual needs of the patient is very important to be kept, or if there is any other job like driving, or this should be reported because it will be different in the management if you have you have a condition that can affect the vision in the patient. Also, history of travel to places that is that has epidemics or specific types of infection, or for example, exposure to tick bites or exposure to mosquito bites, which can transmit certain infections, or specific dieting habits with travel that can be a cause of infection in uveitis. Also, the ethnic group, as you mentioned before, and we mentioned that as an example for those patients coming from the Mediterranean area with prevalence of Behçet disease, and those patients with with the black races, so can be more can has more prevalence of sarcoidosis, and also the patient, for example, both those patients in the United States, the prevalence of the ocular histoplasmosis is higher, so this should be reported. The smoking is a risk factor of recurrence in some specific types of uveitis, and there is a strong evidence that those patients with HLA-B27 associated spondyloarthroposis and HLA-B27 associated uveitis can have more recurrence if they are smokers. So in those patients with HLB27 positive, you need to advise those patients to stop smoking, and it should help with decreasing the recurrence of uveitis. Also, the dietary habits, as we mentioned before, and the taking uncooked meats with possibility of having toxocara or toxoplasmosis infection, or the dietary habits for the milk if it's not boiled enough, so the possibility of brucellosis, the dietary habits of the water ingestion, if there is the source of water ingestion is not clear enough and can transmit certain infections to the eye and can cause uveitis, so this is very important. Also, the growing of pets with like cats in toxoplasmosis, cat scratch disease, and dogs with toxocariasis, so it's very important. Sexual behavior with history of sexual transmitted diseases, and the sexual activities. If you can ask about that, and if it's clear from the history that there is a clear history of sexually transmitted disease, and also the tick bites if you are suspecting Lyme disease with infection Borrelia burgdorferi, so with characteristic inflammation of uveitis and chorioretinitis that is can be correlated to Lyme disease. So this is the main items of the history. So again, so just to summarize, so we are you should be aware of taking the detailed history about every item in the general data and the ocular history, the condition itself, the onset, the duration, the other symptoms, the ocular symptoms of surgery, and trauma, and history of recurrence, and the response to steroids, and the other associated systemic symptoms if there is any. Also, the possibility of sorry, so the possibility of the exclusion of the symptoms, as we mentioned, with the systemic review of the symptom by direct questionnaire to the patient. So you need to ask the patient about each of those symptoms and correlate it with the diseases we mentioned for each system. Okay, so after taking a full and detailed history, you will be able to collect positive data. You'll be able to summarize your data. You'll be able to correlate them with your clinical findings, and then you'll be able to put a broad differential diagnosis before examination. So we mentioned before that in we should be able to diagnose the etiology of uveitis after taking a good history in about 56% of patients, and the examination is increasing this percentage to 73, and only the lab workup is helping you in 5% of patients. So the collection of positive data, summarization of those data, and then correlation between them, and then put a broad differential diagnosis before starting your examination is very important. So this is the end of how to take the history. Just give me a second. Okay, so after taking a good history, you'll be able to move to your next step in your diagnosis, which is the examination and the classification of your uveitis. So the examination is like like your general examination for any patients. You need uh, to report the visual acuity. You need to have a slit lamp biomicroscopy to check the anterior segment and check the full examination of the eye, and you need to report the intraocular pressure if you are suspecting there is a complicated uveitis with glaucoma or ocular hypertension, patients with taking steroids to exclude steroid response, or in those patients steroid responder. If you are suspecting an angle lesion, so you need to do gonioscopy before dilatation when indicated. If you are suspecting an optic nerve dysfunction, so the pupillary examination should be checked before dilatation as well to report if there is any optic nerve dysfunction. And also you need to examine the patient for fundoscopy, including stereoscopic examination of the posterior pole, and examine the peripheral retina and the vitreous as well as part of your examination of the eye. So the differential-based diagnostic system of uveitis uses three clinical features. You need to fulfill all of these features to reach your correct diagnosis. So reporting the location of the inflammation is very important. So to mention that if the inflammation is involving the anterior uvea, if there is an intermediate uveitis, posterior uveitis, or diffuse or panuveitis. So the first thing is the location of the inflammation. Second thing is the type of inflammation. Is it granulomatous or non-granulomatous? And the third thing is there is an associated systemic symptoms. So again, so the location, is it anterior, intermediate, posterior uveitis, or it's panuveitis? Or the type of inflammation is granulomatous or non-granulomatous, and the associated systemic symptoms. By filling the criteria of the types of inflammation, the location, and associated systemic symptoms, you will be able to give a broad differential diagnosis for your patients. So the first item is the location. So the anterior uveitis is the subtypes of the anterior uveitis include the iritis, the iridocyclitis, and the anterior cyclitis. The intermediate uveitis with inflammation of the vitreous. So the subtypes including parasyplanitis, posterior cyclitis, and hyalitis. The posterior uveitis with inflammation of retina or choroid, and subtypes including focal or multifocal or diffuse choroiditis, or chorioretinitis, or retinochoroiditis with the main site of inflammation in the retina and the other main inflammation in the choroid, and retinitis, only retinal inflammation, and neuroretinitis with involvement of the optic nerve. And the inflammation can be panuveitis with diffuse inflammation of the anterior chamber, vitreous, and retina or choroid. So, again, so this is the location of uveitis. Trying to standardize the nomenclature of uveitis for all our patients, to standardize the description of uveitis if you are referring a patient. So it's very important to mention the correct item for the location in your diagnosis. Since 2013, there are very advanced work to standardize the nomenclature of uveitis, and this is related to the location, related to the management, the response to the treatment, and also the types of the inflammation. So we need to agree to a specific scheme or to standardize a specific criteria for diagnosis of the uveitis. So, for example, if you have a patient with acute unilateral non-granulomatous anterior uveitis in a 35-year-old white male with stiffness in the lower back, so it can be easily supposed that this patient may have an HLB27. So in your diagnosis, first you need to exclude the clinical uveitic diagnosis. So there are some types of uveitis that can be diagnosed clinically without any need to correlation to the laboratory workup or or any need for further workup for those patients. For example, those patients with Fuchs uveitis. So this is a very characteristic inflammation involving one eye with the characteristic non-pigmented fine creatic precipitates and the possibility of having glaucoma and the cataract, and as we mentioned, the ocular hypertension, and some of those patients can have some vitreous cells. So the changes in the iris with heterochromia is very important in diagnosis. So this can be very easily diagnosed clinically without any need for further workup for those patients. The second item is Behçet disease. Those patients usually presented with retinal vasculitis, mainly with severe drop of vision. If the vascular element is occlusive and causing retinal artery occlusion, retinal vein occlusion, so the drop of vision will be severe. And taking a detailed history of those patients, it's definitely you will find the history of orogenital ulcers in the history, and can be easily diagnosed clinically then. The toxoplasmosis clinically can be diagnosed by the characteristic chorioretinal pigmented scar with the affinity to the macula and with satellite lesions with recurrent inflammation and the history of contact with infecting cat or source of infection to the toxoplasmosis. The cytomegalovirus retinitis, sorry. It's presented mainly by optic disc edema with hemorrhages and exudates all over the posterior pool, and there is a history of involvement of systems in, for example, if the patient has history of hepatitis or jaundice, so it can be correlated easily with the findings in the retina. Ocular histoplasmosis can be easily diagnosed with the triad of histoplasmosis, with peripapillary atrophy, histospots in the posterior pool, and choroidal neovascular membrane of the macula. And lastly, the Vogt-Koyanagi-Harada disease with the characteristic bilateral exudative retinal detachment, serous pigment epithelium detachment in many areas all over the posterior pool, and also systemically by the central nervous system symptoms and the vitiligo or skin lesions and the auditory symptoms, if any. So it's very easy to diagnose those if you have clinically, if you have any of those diseases, and she's easily diagnosed. The anterior uveitis. So again, just to standardize how to describe the anterior uveitis, so it's very important to grade the cells and to grade the flare in the anterior inflammation. So if the cells is less than 1, so you cannot find any cell, so it will be grade 0. If the cells are from 1 to 5 in 1 millimeter field, so it will be graded plus 0.5. If there are cells 6 to 15, so it will be graded as plus 1. 16 to 25 will be graded as plus 2. 26 to 50 will be graded as plus 3, and more than 50 will be graded as plus 4. So this is the grading according to the anterior chamber cells. According to the flare, so if there is no flare, so this will be grade 0. If there is a faint flare, this will be grade 1. If there is the media and description of the iris and lens details can be clear, so it's a moderate flare, it's plus 2. The marked flare, if the iris and lens details are hazy, so it will be plus 3. If there is a fibrin or plastic opaques and there is an intense reaction inside the eye, so it will be plus 4. So the main causes of uveitis, the anterior uveitis, most types of anterior uveitis are sterile inflammatory action as opposed to many of the posterior uveitic syndromes that are caused by infections. But the most common causes in anterior uveitis is idiopathic. So about 38 to 70% of patients can be idiopathic. HLB27 positive or HLB27 associated disease, including ankylosing spondylitis, Reiter syndrome, inflammatory bowel disease, psoriatic arthritis, and post-infectious arthritis. Trauma in 5.7% of patients, herpes simplex in 12.4% of patients, varicella zoster in 5 to 6% of patients, syphilis, tuberculosis, Lyme disease, and sarcoidosis, which classically can be presented by granulomatous uveitis, but it can be presented by any type of uveitis. So I have many patients with sarcoidosis, which was presented by just anterior uveitis without an involvement in the of the posterior segment, and usually the inflammation is not granulomatous inflammation, despite the patient has a clear history of sarcoidosis. So, when to order a test in anterior uveitis? Do you need an order test for every uveitis patient? Of course, no. Okay. And what to order? Are you going to order every test so that hopefully something will turn positive and then you will reach your diagnosis? Of course, no. So, when you need to request for laboratory workup for your patients of anterior uveitis. So anterior uveitis workup required only if the inflammation is bilateral, recurrent, chronic, if the inflammation is granulomatous, if the inflammation is unresponsive to steroids, if the inflammation involving the posterior segment as well. So you need to ask about laboratory workup. And if there is a positive review of system that needs to be confirmed with your laboratory workup, so you will request workup for those patients. So again, bilateral, recurrent, chronic granulomatous, unresponsive inflammation with posterior segment involvement and with a positive review of system that needs to be highlighted. The main laboratory testing for anterior uveitis include the full blood count, the urine analysis, the hemoleucocytic antigen B27, the angiotensin converting enzyme for those patients with sarcoidosis, the venereal disease research laboratory test, and rapid plasma regain for those patients with suspecting sexually transmitted disease and syphilis, fluorescent troponemal antibody test for those patients with suspecting syphilis, and chest radiography for those patients with suspecting sarcoidosis and tuberculosis. Those are the main. So any anterior uveitis laboratory workup should involve all these. Beside, if you are suspecting anything else, so it should be requested as well. So this is the anterior uveitis diagnosis. So with management of those patients, how to grade the response to the management with and to describe it in our standard way of our accepted description. So, so the inflammation will be inactive if there is the patient reached grade 0 cells with your medication and management. So worsening activity means that there is two-step increase in the level of inflammation with follow-up. So there is a two-step increase in the level of inflammation in the anterior chamber cells or vitreous haze, or increase from grade 3 to grade 4. Improved activity means that the patient has two-step decrease in the level of inflammation. For example, anterior chamber cells are decreasing, vitreous haze is decreasing or decreased to grade 0. Remission means that there is an inactive disease for more than 3 months after discontinuing all treatments by diseases. So inactive, worsening, good activity, and remission. So this is related to the diagnosis and management of anterior uveitis. In intermediate uveitis, the commonest causes are idiopathic, sarcoidosis, and this can be easily diagnosed by history, as I mentioned, multiple sclerosis with history of demyelination or history of central nervous system symptoms, Lyme disease with characteristic target lesion, tick bite history, inflammatory bowel disease or Weber disease, ulcerative colitis, and Crohn's disease. And in those patients with old age presenting with vitreous cells, you need to think about intraocular large cell lymphoma. So the main workup of intermediate uveitis should involve those and should include angiotensin converting enzyme chest radiography, gallium scan biopsy for those patients with sarcoidosis, MRI scan for those patients with suspecting multiple sclerosis and or any history of neurologic central aortic neuritis, and usually Lyme serology for those patients suspecting Lyme disease by immunoglobulin G or immunoglobulin M, if the patient came from endemic area or presence of systemic signs, as we mentioned before, venereal disease research laboratory test, and fluorescent epidermal antibody tests for the suspecting syphilis, gastrointestinal tract consultation if you are suspecting inflammatory bowel disease, and the vitreous cytology with immunophenotyping with lumbar puncture for cytology if you are suspecting intraocular large cell lymphoma. Retinal vasculitis, the differential diagnosis of retinal vasculitis can be subdivided broadly into those diseases that have systemic involvement and those just confined to the eye. Most cases of retinal vasculitis can be idiopathic, and sometimes it's called Ehl's disease. And the many of systemic disease can be of clinical diagnosis by taking a good history. And we mentioned before how to diagnose those if you have suspicion of Behçet and systemic lupus erythematosus. So this is the main scheme for diagnosis of retinal vasculitis and the flow chart that you need to use to evaluate those patients with retinal vasculitis. So if you have a patient with retinal vasculitis, first you need to rule out some diseases that can be associated with some vascular changes resembling the retinal vasculitis. So first, rule out diabetic retinopathy, rule out radiation retinopathy, rule out vein occlusion, rule out hyperviscosity syndrome, or venous stasis, rule out sickle cell retinopathy. If you can rule out those, so sorry, by ruling out those, you'll be able to limit your diagnosis to retinal vasculitis, and then you request some blood test and some investigation for diagnosis. So the main blood test you need to request is to request the fluid blood count, as we mentioned, urine analysis, angiotensin converting enzyme, chest X-ray, fluorescent troponemal antibody test, fluorescein angiogram for differentiation between occlusive and non-occlusive retinal vasculitis. Based on the findings, so if there is an evidence of systemic disease, fever, malaise, weight loss, arthritis, rash, with retinitis, so if there is evidence of this systemic disease with retinitis, so your diagnosis will be one of the following: will be either cytomegalovirus retinitis, toxoplasmosis, candidiasis, Behçet disease, herpes zoster or simplex, syphilis, lymphoma. And based on that, so evidence of systemic disease with retinitis, so you request further investigations to exclude those etiologies. So you need to have a medical evaluation for those patients. You need to make serology for toxoplasmosis and herpes and HIV. If you're suspecting candidiasis, so candida culture or blood culture can be done to exclude candidiasis. Also, syphilis will be excluded by fluorescein troponin antibody test and rapid plasma regain, lumbar puncture and angiotensin converting enzyme, and neuroimaging for those patients with suspecting lymphoma, vitreous biopsy, as we mentioned, for lymphoma as well, and analysis of the vitreous biopsy if you are suspecting lymphoma. In those patients with evidence of systemic disease with presence of occlusive vasculitis, that is, can be easily diagnosed by fluorescein angiography. So your diagnosis will be either Behçet disease, systemic lupus erythematosus, polyarthritis nodosa, Wegener's granulomatosis, sarcoidosis, and giant cell arthritis. So based on that, the investigation you need to request is HLA-B5 for Behçet disease, anti-nuclear antibody, and the serology for diagnosis of the systemic lupus erythematosus, erythrocyte sedimentation rate and C-reactive protein, cytoplasmic antineutrophilic cytoplasmic antibody for diagnosing of Wegener's granulomatosis, and angiotensin converting enzyme for sarcoidosis, temporal artery biopsy if you are suspecting giant cell arthritis, and biopsy of other diseased tissue if you are suspecting a granulomatous inflammation that can involve other tissues like sarcoidosis. And if there is an evidence of systemic disease with non-occlusive vasculitis, so the possibility of multiple sclerosis, Lyme disease, sarcoidosis, Weber disease, inflammatory bowel disease, Crohn's disease, and rheumatoid arthritis and polymyositis. So in those patients, you need to have an MRI scan with neuroimaging to exclude demyelination, Lyme serology to exclude the Borrelia burgdorferi infection, angiotensin converting enzyme to exclude sarcoidosis, and chest X-ray as well, gallium scan for sarcoidosis, and muscle enzyme for excluding polymyositis. If there is no evidence of systemic disease, so still if there is no evidence of systemic disease, so your diagnosis will be one of the following: will be either acute retinal necrosis, frost branch angiitis, birdshot retinochoroiditis, Eales disease as an idiopathic inflammation, barciplanitis, toxoplasmosis, retinal arthritis, and aneurysm. So the retinal vasculitis with no evidence of systemic disease. So acute retinal necrosis, frosted branch angiitis, birdshot retinochoroiditis, Eales disease, barciplanitis, toxoplasmosis, retinal arthritis, and aneurysms. And in this case, no further workup is required. So possibly you will get one of those workup positive for diagnosis of the pathology in this category of the inflammation. So in retinal vasculitis, the main workup should include fluorescein angiography. These two classify if the process of the vasculitis is occlusive or non-occlusive, the full blood count, the urine analysis, the fluorescent troponemal antibody test, angiotensin converting enzyme, chest radiography. So those are the main diagnostic workup, and based on your clinical findings and the history, as we mentioned in the flow chart of the diagnosis of retinal vasculitis, you request further workup based on that. In those patients with uveitis or granulomatous inflammation that is involving all the tissues of the eye, so you need to exclude the multiple sclerosis, the sarcoidosis, Behçet, Vogt-Koenigke Harada, and never forget the infections like herpes, tuberculosis, cytomegalovirus infection, fungal infection, and toxoplasmosis infection. And always remember, masquerades, if you don't have any positive data, can be correlated to those conditions, either infection or generalized condition like multiple sclerosis, sarcoidosis, Behçet, and Vogt-Koenigke Harada. So uveitis mainly can be caused by granulomatous inflammation like sarcoidosis, and some other entities of the pathology can be involved, like, as we mentioned, multiple sclerosis, and the vitreous element here with and intermediate uveitis is higher. In Behçet, definitely you will find some vasculitic element, and in Vogt-Koenigke Harada, it's easy to be diagnosed by exudative retinal detachment with presence of granulomatous inflammation in other parts of the eye. The infections are very important, and those can also be excluded by history. And don't forget the masquerades if you fail to reach a specific etiology. Lastly, the inflammatory chorioretinopathies can be sarcoidosis, Vogt-Koenigke Harada, sympathetic ophthalmia, plasmodia carinii, choroiditis, ocular large cell lymphoma, white dot syndrome, can all presented with inflammatory chorioretinopathy. We will take that in details. Most of white dot syndrome have little, if any, anterior vitreous cellular activity except birdshot retinochoroiditis, which can be associated with significant vitritis without snow banking, retinal vasculitis, and striated macular edema. The workup of those patients with inflammatory chorioretinopathies should involve fluorescein angiography and mainly HLA A29 in those patients with suspected birdshot chorioretinopathy. So this is the end of our first part of the lecture. So we will try to apply what we mentioned in the diagnosis to some cases. So we will have 3 cases. The first case is a 51-year-old female patient presented with complaint of headache and redness in both eyes 5 days ago. This patient noticed that her pupils are always dilated and reported seeing halos and some blocked areas in her peripheral visual field in the left eye. And the patient denied any history of pain or flashes in both eyes. By taking the history of the patient had history of presentation to the emergency department before 1 week of coming to you, and there was a complaint of colored lights in both eyes, pain and light sensitivity, followed by headache when she woke up. And those symptoms appear after an attack of sinusitis treated by levofloxacin, and the condition improved after immediate administration of acetazolamide and tetracaine. Then she was discharged on topical steroids and dilating eye drops. So from this history, you can assume that the patient has history of angle closure glaucoma or suspect ocular hypertension, and that's why the patient was given acetazolamide and at this time to control the pressure in the eye. The past medical history of the patient include dyslipidemia and bronchial asthma, and the patient also is on those drugs, in some antibiotics with suspected infection, levofloxacin, varavastatin, vastatin for dyslipidemia, and some inhalers for her bronchial asthma and medications for controlling her asthma. Also, the patient topically she's using the ciprofloxacin eye drops since she was discharged from the emergency department, and using steroid eye drops, and she's on an eye ointment, the bestrosine. The examination of the patient, the vision in the right eye was 20/30 and the left eye was 20/20. The refraction showed low-grade hypermetropia, and the pressure was normal in both eyes, and the pupils were dilated in both eyes, diameter of 4 millimeter and slow reaction. The slit lamp examination showed no conjunctival injection. Cornea showed few endothelial pigments in the right eye. Bilateral pigmented cells in the anterior chamber in both eyes, +1 in the right eye and +2 in the left eye. Transillumination iris defects in both eyes. Gonioscopy, we showed heavily pigmented trabecular meshwork in both eyes, but the angle was open. Lens had early nuclear sclerosis in both eyes, and fundus examination was within normal. So this is the clinical picture of the patient. So it's similar in both eyes. So you can find the transillumination iris defects. There is an endothelial pigment. There is an old pigmented cells from the old inflammation in the anterior chamber, +1 in the right eye and +2 in the left eye, and also there is an nuclear sclerosis, and the pressure is normal, and the fundus examination was normal. So the question is, this patient, what is the differential diagnosis, and what uveitis, and is there any in the history that can guide you for that? So let us first see the differential diagnosis, as we mentioned, is idiopathic between herpes simplex, varicella zoster, syphilis, sarcoidosis. We had some workup for this patient to exclude those. So the patient had a visual field which was unreliable. HLA-B27 was negative and the genetic conversion was negative. So sarcoidosis and HLA-B27 can be excluded. And the rheumatoid factor, tuberculin test and chest X-ray. Tuberculin test was negative. Chest X-ray showed mild chronic appearing pulmonary interstitial changes that might be consistent with her history of bronchial asthma. And immunoglobulin G antibodies for cytomegalovirus, herpes simplex virus, and the rapid plasma regain for tuberculin antibody Lyme disease, all of them came negative. Is there anything else you will suspect the history? So, did you ever hear about drug-induced uveitis? This is a very important topic, as we mentioned. In detailed drug history, you can highlight some of the drugs that can be correlated to the condition of the patient. So drug-induced uveitis has been reported in association with a number of systemic intraocular and topical medication. Most of those cases respond promptly to discontinuation of suspected agents in conjunction with topical corticosteroids and cycloplegic therapy. And the systemic drugs that was reported as a possible contributing cause of uveitis include cidofovir, rifabutin, bisphosphonates, sulfonamides, and anti-tumor necrosis factor agents. Approximately, there is 40 cases of uveitis associated with systemic but not topical or intraocular fluoroquinolones, including ciprofloxacin, ofloxacin, gatifloxacin, levofloxacin, and norfloxacin have been identified since 2004. Moxifloxacin has been commonly implicated in the diagnosis and can cause also drug-induced uveitis. So if we return to the history of the patient, you will find that the patient has history of an attack of sinusitis treated by levofloxacin. And by taking a detailed history of the patient, so the patient reported that the condition of the eye was returned twice after taking the same medication. So this patient can be one of those patients with drug-induced uveitis with levofloxacin. Drug-induced uveitis with the mechanism of drug-induced uveitis can be by direct drug toxicity or indirect effects such as immune-mediated vasculitis seen with quinidine, or can be related to the direct drug toxicity. Uveitis reported with fluoroquinolone therapy may actually be a more type of pseudo-uveitis caused by phototoxicity resulting in iris pigment release and secondary inflammation rather than a true uveitis. And the autoimmune predisposition in those patients was found related to the HLB27 and HLB51 in 20% and 40% of tested individuals respectively. So, quinolones-induced uveitis in those reported cases usually are bilateral uveitis with a median duration of 13 days with starting the drug, and the patient presented with bilateral ocular pain and visual impairment. Usually, there are fine pigmented keratic precipitates on the with prominent pigment in the anterior chamber in those patients, and there is a diffuse iris transillumination. Defects with atonic pupils are also characteristic. Nearly one half of the affected patients can develop ocular hypertension, and this may be the scenario of the old attack of inflammation in our patient. And the iris atrophy and the atony may be permanent in those patients bilaterally. So this can be easily differentiating point between it and between Fox uveitis. So still, despite in the history, this patient can be a drug-induced uveitis, it's a matter of debate. So the study in 2013 by Fogan doesn't provide convincing evidence of an association between fluoroquinolones and uveitis. And they mentioned that there is an association between several classes of antibiotics and uveitis, not specific to fluoroquinolones. And there is a possible that the systemic process for which these antibiotics are being prescribed are in fact the inciting factors of the uveitis. For example, this patient was receiving fluoroquinolones or fluoxetine for treating uveitis, so there may be a possibility of association between the infectious sinusitis and the uveitis. But as it's bilateral, so still it's a matter of debate that the drug can be the cause of uveitis. So another review in 2015 showed that there are several agents with different routes of administration, systemic, topical, and intraocular, may cause intraocular inflammation. And the mechanism behind ocular inflammation is frequently unknown, and the clinicians should be aware of the potential drug effect to optimize diagnosis and management of any patients with suspected drug-induced uveitis. So this is the end of our first patient. We are going now to move to the second patient. So our second patient is a 37-year-old female patient presented with a complaint of blurred vision, floaters, and pain, mainly in the right eye, since 1 week. The patient has past history of recurrent central serous choroidenopathy and later diagnosis uveitis. The symptoms appear after discontinuation of oral steroids, and she had myopia with relative amblyopia in the right eye. The past medical history include headache, tinnitus, hypothyroidism, sinusitis. The patient on levothyroxine for her hypothyroidism, and she was treated for tinnitus, and she discontinued oral steroids for uveitis 1 week. And now she's using topical steroids. The examination revealed that the visual acuity was 100 in the right and 60 in the left, and the myopia was revealed by the automated refraction, and the pressure was normal in both eyes. The pupils showed posterior synechiae in both eyes. Slit lamp examination showed mild conjunctival injection, mainly in the right eye. Cornea showed new and old pigmented keratic precipitates in both eyes, anterior chamber cells. The anterior chamber in both eyes was +1. Posterior synechiae in both eyes. Lens had right posterior subcapsular cataract, in uveitic cataract in the right eye more than the left eye. As you can see here, this is a fundus picture of the patient. There is a vitreous haze in the right eye with severe vitritis, vitreous cell +2 in the left eye, myopic fundus degeneration in both eyes, optic disc hyperemia, bilateral serous macular detachment with multiple serous detachment in the periphery, as can be seen mainly in the left eye. So the differential diagnosis and the uveitis workup, again, if there is any clue in the diagnosis and what are lines of treatment. So the patient had fluorescein angiography, and you can see the dense media opacity in the right eye with no clear view, and there is an optic disc hyperfluorescence in the left eye with areas of the, which I think it's not clear here, so it's areas of serous macular serous detachment in the periphery of the retina. So the OCT of the left eye showed a cystoid macular edema, and the B-scan ultrasonography of the right eye showed the retina is flat and there is a dense vitreous reaction. So again, what's the difference? What is uveitis? Is there any clue in the what are line treatment? If we go back to the history of the patient, the past medical history. So this patient had history of headache, tinnitus, hypothyroidism, and sinusitis, and probably those symptoms are related to vestibular auditory symptoms and central nervous system symptoms. So you may suspect this patient with the clinical findings and the serous detachments in both eyes, and the patient may have Uveitis. So Uveitis is a multi-systemic disorder with granulomatous uveitis and excessive retinal detachment with neurological and cutaneous manifestations. It's a cell-mediated autoimmune disease directed mainly against uveal, dermal, and meningeal melanocytes. It's associated with other autoimmune disorders like autoimmune polyglandular syndrome, hypothyroidism, Hashimoto thyroiditis, diabetes mellitus, Guillain-Barré syndrome, immunoglobulin A nephropathy, and this syndrome may also be reported to be linked to malignant lymphoma. The comment to Vöktikonagi Harada, you need to have those exclusion before diagnosing Vöktikonagi Harada. So you shouldn't have a prior history of ocular trauma or surgery. You shouldn't have an evidence of another ocular disease based on clinical or laboratory evidence, and it should be bilateral involvement. The complete Vöktikonagi Harada involved diffuse choroiditis with focal areas of delayed choroid perfusion, multifocal pinpoint leakage, or blacoid hyperfluorescence, pooling of subretinal fluid, and optic nerve staining by fluorescein angiography, and lately ocular depigmentation and nummular chorioretinal scars, retinal pigment epithelium forming and migration. Incomplete Vukti-Koegi Harada will be shown by non-neurological and auditory manifestations or integumentary signs, but not both. Probable Vukti-Koegi Harada with only isolated ocular disease. The ocular complications include cataract, closed-angle glaucoma with different mechanisms, including pupillary block, forward rotation of ciliary body, open-angle glaucoma, subretinal fibrosis, choroidal neovascularization of the disc, pigmentary changes of the fundus, and optic atrophy. Systemic complications include neurological manifestations, cutaneous manifestations in the form of alopecia, foliosis, and vitiligo. Auditory manifestations involve in the form of hearing loss or loss of balance or vestibulo-cochlear symptoms. The disease has some stages. The prodromal stage is headache, meningitis, nausea, vertigo, orbital pain, tinnitus, cerebrospinal fluid, pleocytosis, photophobia and tearing, and uveitic stage with acute bilateral blurring of vision, bilateral posterior uveitis with retinal edema, optic disc hyperemia or edema, and serous retinal detachments. The chronic stage with ocular and dermatologic manifestation, depigmentation of the choroid, Dallenfox indules dermatologic changes, vitiligo, and poliosis of the lashes, eyebrows, and hair. Recurrent stage, recurrence of chronic anterior uveitis, low-grade choroidal inflammation, and recurrent posterior uveitis with serous retinal detachment. So the anterior segment manifestation in the eye include perilumbal vitiligo, which is called Shugwira sign, granulomatous inflammation in the anterior segment or non-granulomatous anterior uveitis, posterior synechia. Posterior segment can have many findings, include anterior vitreous cells, retinal edema followed by the development of bilateral multifocal serous retinal detachment, depigmentation, demarcation lines and areas of hyperpigmentation, red-orange appearance of the sunset glow fundus, subretinal fibrosis, retinal pigment epithelium migration, and disciform scars also may occur. Neovascularization of the disc and retina, choroidal neovascularization of the macula can be one of the complications of the Vukti-Koegi Harada and chorioretinitis in Vukti-Koegi Harada. And the investigation you need to have for those patients, fluorescein angiography, ultrasound in those patients with dense vitritis, OCT scanning to confirm the pigment epithelium detachment and serous detachment and exudative retinal detachment, MRI scan to exclude multiple sclerosis, electrophysiology for diagnosis of the optic nerve function and any electrophysiological deterioration with the disease, histopathologic findings with non-granulomatous inflammation with the plasma cell infiltrates, lymphocytes, multinucleated giant cells, and epithelioid cells. So in this patient, the scenario was as follows. So the patient presented with a dense vitritis in both eyes, as we mentioned, and she was on oral steroids, but still there is a dense inflammation. So the patient had intravitreal trimethylene acetonide. At this time, the Ozurdex was not available, so the vision improved after 2 months to 40 in the right and 30 in the left, and there is serous detachment resolved in both eyes, and the pressure was normal in both eyes. After 5 months of the first injections, the patient developed recurrence again, and the patient at this time was still on oral steroids, but the vision dropped to 160, 100 in the right and 60 in the left, and there was cratic precipitated vitritis and posterior subcapsular cataract in both eyes, and posterior synechia with multiple serous detachment, and the pressure was fine. So I plan to give this patient a second intravitreal trimethylene acetonide in both eyes. And after 1 month, the vision improved again to 60 in the right and 400 in the left, and there is an improvement with some residual activity after 1 month. The pressure was normal in both eyes. The patient developed they still have some residual activity. So I start cyclosporin to 25 milligram 3 times a day for patient to control the inflammation. After 3 weeks of cyclosporin therapy, the vision little bit stable in right eye. It's 100 in right eye and 200 in the left eye, but the cataract increased in both eyes despite improving of uveitis, mainly in the left eye more than in the right eye. The pressure was normal. So I plan to have a cataract surgery in both eyes after 3 months of inactivity or quiescence. And the patient had cataract surgery in both eyes, subtenon triamcinolone injection, and the vision improved to 28 in the right and 28 in the left. And the eye was totally quiet in both eyes, and the pressure was normal. The patient was so happy at this stage, and she continued. She was on cyclosporin this time. She came after 5 months of the cataract surgery with left dense posterior capsular opacification and the recurrence of uveitis serous retinal detachment. And at this time, I shifted from cyclosporin to azathioprine, but unfortunately, the patient was intolerant to azathioprine. She developed pancreatitis. So after 2 weeks of the developing intolerance to azathioprine, and the vision was 40 and 50, and the posterior capsular opacification was increasing in both eyes, and despite improvement of uveitis. So, and this was the OCT of the patient this time. You can see the OCT macula is dry in both eyes. So we changed to cyclosporin again, and start slow tapering of oral steroids, and the patient was planned to YAG laser posterior capsulotomy. After laser posterior capsulotomy, after 6 months of stable condition, YAG laser posterior capsulotomy, the vision was 40 in the right and 400 in the left. There is no activity of uveitis under cyclosporin therapy at this stage, but unfortunately the patient developed left choroidal neovascular membrane. So I inject, as you can see here with the OCT, there is a choroidal neovascular membrane here. So I acted the patient at this stage with intravitreal Eylea in the left eye, and the vision improved from 400 to 300 after the first injection, and it was stationary in the right eye to 225, but still the choroidal neovascular membrane was active after 1 month, and no uveitic activity on cyclosporin. So the patient still have an active choroidal membrane. So the second injection was given to this patient. It's a very long history. You can see here, despite the control of the inflammation, one of the complications of the inflammation is affecting the vision of the left eye, which is the choroidal neovascular membrane. So the choroidal neovascular membrane here can be a part of the complication of the old inflammation in the eye, or can be part of the myopia that the patient have. So it's either a myopic choroidal neovascular membrane, or it may be a complicated choroidal neovascular membrane on top of a chorioretinal scar in the macula following the healing of the inflammation in the eye. So this is the end of our second case. Case number 3 is a 38-year-old male patient presented with complaint of blurred vision in left eye 3 days ago. The patient denied any history of pain or flashes in both eyes, and the past medical history has hypertension. The blood pressure at the time of the presentation was 180 over 120. The patient discontinued the case of hypertension a few months ago. So there is no current topical eye medication. So the examination showed that the vision was 20 in the right and 70 in the left, and there is a mixed myopic astigmatism with pressure normal and pupils in the anterior segment normal. The examination of the patient, so the right eye was totally normal, and the left eye showed multiple small whitish, well-defined dots and the spots, as you can see here. Okay, so and it's located predominantly berry and macular area. So, what is the diagnosis in patient? What is uveitis required? So, this is a very clear diagnosis of white dot syndrome. So, the white dot syndrome are a group of idiopathic multifocal inflammatory conditions involving the retina and the choroid. They are characterized by the appearance of white dots in the fundus. So, the white dot syndrome has a broad spectrum of disease: acute posterior multifocal placoid pigment epitheliopathy with characteristic whitish larger lesions over the posterior pole, serpiginous choroiditis with characteristic peripapillary atrophy and the chorioretinal infiltration, which is taking papillary area and serpiginous pattern resembling the tuberculous choroiditis, multiple evanescent white dot syndrome with the characteristic white lesion all over the posterior, and the multifocal choroiditis and panuveitis with vitreous inflammation and panuveitis, involvement of the anterior segment with multifocal choroidal inflammation, punctated inner choroidopathy with punctated inner inflammation involving the macular area with association with choroidal vascular membrane, the subretinal fibrosis with evidence of subretinal fibrosuppressants and subretinal fibrosis changes underneath the retina, presumed ocular histoplasmosis, triad of histo spots, papillary atrophy in the choroidal vascular membrane, and birdshot retinochoroidopathy with characteristic lesions of birdshot choreo retinopathy, as you can see here. Return to the fundus picture. So I put a differential diagnosis of one either acute posterior multifocal placoid pigment epitheliopathy or multiple evanescent white dot syndrome. And diagnostic criteria of those entities in white dot syndrome is varying. So the acute posterior multifocal placoid pigment epitheliopathy mainly prevalent in young adults, but multiple evanescent white dot syndrome mainly prevalent in young to middle-aged females. So our patient is a male patient, so this can be a positive finding with acute posterior multifocal placoid pigment epitheliopathy. So acute posterior multifocal placoid pigment epitheliopathy is bilateral condition with acute penless loss of vision, but in multiple evanescent white syndrome, it's a penless acute unilateral loss of vision. So this is positive for the multiple evanescent white dot syndrome because our patient is unilateral. The prodromal fever, myalgia, headache, and malaise can be one of the criteria of acute posterior multifocal placoid pigment epitheliopathy, which can be obtained here. And the viral prodrome is present in 50% of patients with multiple white dot syndrome, and this is cannot be excluded in this patient. So, again, this is our fun picture, and this is our fluorescein angiography. You can see here there is multiple hyperfluorescent spots with increasing in the late phases. Its level is the subretinal base, and there is no element of colitis and no element of fibrosis. The OCT of the patient showed higher granularity of the macula corresponding to the infiltrates, as you see here. And from here we can put differentiation between the both items, again, the acute posterior multifocal placoid pigment epitheliopathy and multiple evanescent white dot syndrome. So this patient didn't have vitreous cells, and this patient has the criteria of the acute multifocal bilicoid endotheliopathy, the criteria of the lesion, which is flat yellow white bilicoid lesion, the posterior pool ranging in size from 0.5 to several disc diameters that become less opaque within 2 or 3 weeks and develop pigmented changes at the level of the retinal pigment epithelium. This is not the criteria of our inflammation, but our lesions is flat, multifocal, gray-white lesions, deep and the right pigment epithelium outside the macula, the posterior pool, and ranging in size from 100 to 300 micron in diameter. So this is approved here as a multiple evidence white dot syndrome. So I managed the patient till now the multiple evanescent white dot syndrome. This is confirmed by the foveal granularity by OCT, and also still the multiple evanescent syndrome can be associated with optic disc edema, which is not found there. So after 1 week of follow-up, usually this patient had uncontrolled hypertension, so I was not able to start oral steroids before starting to control the blood pressure first. So the main priority was to control the blood pressure. So the blood pressure was controlled, and there is a possibility that the condition of multiple evanescent white dot syndrome can be self-limited without steroids. But the patient came to me after 1 week of follow-up and assurance with still the vision is in the left eye 20/70, and now the patient developed left splinter inferior disc hemorrhage and progressive lesion with scarring. So as you can see here on this picture after 1 week, and you can see here the splinter hemorrhage here. I decided to give them oral steroids after 2 weeks. The lesions are improved in the vision, improved FT, and the pressure was normal. And this was the big after 2 of oral steroids. So you can see the lesions are in size, and now the bleeding disappeared. So, and this is the OCT after 2 weeks of oral steroids. So you can see the foveal granularity improved in the left eye. After of oral steroids, the vision improved to 20, and there is more improvement of the lesion, and the pressure was this time. So you can see from this picture after 1 month of steroids, so the lesions disappeared totally, and there is an improvement of the vision to 20. Also, the showed that the foveal granularity totally disappeared in the left eye. So this is the end of our last patient. So my big message for uveitis patients. So when you're evaluating a patient with uveitis, so detailed ocular history, symptoms, duration, laterality is very important. Thorough ocular examination, anatomic location, type of inflammation, any typical entity should be reported. Systemic history, targeted questions, the uveitis questionnaire is very important to be asked, and only select investigations, if any, not to request for many investigations for patients. And be careful if you are suspecting infection, if there is a severe inflammation, if there is a chronic inflammation in the eye, there is no response to aggressive treatment, and if there is a posterior involvement, as there is uveitis in children. So this is the last take-home message. Thank you for attendance today, and don't forget about this guy which is breaking the wall to the correct diagnosis. Don't follow the others who are in the difficult ways to reach their diagnosis. Take a good history taking. Take a good history, and be sure that you are reporting everything in your history with uveitis questionnaire and the systemic review, and be sure that you are following the steps of diagnosis as well. Thank you so much for your attendance, and I'm sorry the interrupt at the beginning with basic platform. I hope you you got back from this lecture so much. See you. Thank you.